I'd like to call up to stage Dr. Erez Dayan. He's going to be speaking about post-hyaluronic acid recurrent eyelid edema, a role for fractional radiofrequency.
Okay, thank you guys very much for the invitation. So the topic of this conversation is kind of twofold. The first part is talking about filler complications, especially in the periorbital area, and then the solutions for it. Actually, we wrote an article in the Aesthetic Surgery Journal a few months ago that Dr. Varanis was part of. Here are my disclosures. I owe a lot of credit to Dr. Dan Baker, who's a mentor of mine, for really bringing filler complications to light. These are his slides. He gave this at the Baker-Gordon conference a few years ago, and that's really what triggered a lot of this work. This is a facelift case of Dr. Baker's where he really highlights that fillers last a lot longer than we think, and I think most people kind of know that, but it's not really well defined. So back when I was actually in my general surgery residency, we started doing imaging for lymphatics, for lymph node transfer. And I built an indocyanine green camera to kind of map out lymphatics. And basically, here you can see a dye is injected into the web spaces of the hand, and you can use fluorescent dye to map out your lymphatics. So we started doing this on patients that have had fillers, particularly periorbital fillers, with and without chronic swelling. And in control cases, you really don't see this kind of stardust, cloudy pattern of the filler. So we know that periorbital lymphatics are particularly sensitive to filler, and we try to define why and then what's the solution to it. So, you know, the rate of delayed edema is not really well defined. Nobody really knows how long it lasts, and the reality is there's probably many underreported cases. There's a lot of things about fillers that we're not really clear on. For example, do they migrate to lymph nodes? This is a case of Dr. Baker's where the lymph node was excised, seen under pathology, shown to have hyaluronic acid that migrated to it. And if you look online, many patients realize that fillers last longer than we think and can cause issues. The rheumatologists always highlight this. So two notions are lacking is the long-term safety and reversibility. Basically, every 20 years, there's a great article written by Alex Rivkin about the history of fillers. And basically, every 20 years, a new filler comes out and some of the complications are seen. So we're at about the 20-year mark for hyaluronic acid. The thing about hyaluronic acid is it is a natural substance. The issue with it, however, is that in its natural state, it doesn't last long enough. So it has to be cross-linked. And also, we want more of a G prime sometimes. So it's cross-linked to make it last longer and also have more of a firmness to it. The issue is sometimes it's cross-linked so much that it can cause chronic edema and issues that are very difficult to reverse. So this is an example. This is a little video from Allergan. Hopefully they're not here watching. But the Vicross technology basically is a proprietary way of cross-linking. And we find that oftentimes, especially with these Vicross fillers, especially in the tear trough area, there can be chronic swelling. This is an article in PRS. Basically, it's not advisable to modify the hyaluronic acid molecule to such a large extent that it's identified as a foreign body. And actually, if you looked at some of the data with the Moderna vaccine, patients that had Moderna vaccines had, in some cases, had swelling where a filler was placed even years before. So there's some low-level inflammatory process, and I want to show you kind of what it is and then what our solution is to solve it. So they last longer than we think. These are some examples of patients, especially in the periorbital area, tends to be particularly sensitive. There have been studies of fillers lasting up to 10 years, imaging studies, co-injection with neurotoxins can prolong that. This is a case from Dr. Kami Parsa, who's an oculoplastic surgeon in Beverly Hills. As you can imagine, he sees a lot of this and came up with a lot of the protocols for treatment. But this is filler that migrated into the orbital fat. And you can see here on pathology, the blue is hyaluronic acid. So they can cause chronic edema and lymphatic obstruction. Now, these are examples. So this is what we call FARI, post-hyaluronic acid recurrent eyelid edema. A very difficult problem to correct. Now, some of these patients are just generally overfilled and kind of have almost the lymphedema picture of the whole face. So the question is why it happens, and I'm not going to run out of time here. So let me fly through it and then show you the solution. So there's a septum, malar septum, that's rather impermeable that can kind of hold the filler up. The lymphatics around the periorbital area are the only lymphatics in the body that do not have valves. It's not directional. Lymphedema in general has been shown to be a T-cell mediated inflammatory response. So the malar septum, which was most recently described by Pessa, is about 2.5 centimeters inferior to the lateral orbital rim. It's rather impermeable, so if you inject filler above that, it's hard for the filler to get out. The lymphatics are delicate around the eye, and there's actually a watershed area right where we tend to want to inject for the cheek area. And also the lymphatic channels here don't have valves. Lastly, lymphedema is found to be a T-cell mediated process, so there's been some data shown at Memorial Sloan Kettering in the lymphedema world that in order to get chronic swelling, you have to have T helper cells. And that correlates to how the Moderna vaccine may have caused swelling in patients that have had fillers. So long story short, what's the solution to these cases? Because it's something we see often, and we know that hyaluronidase kind of isn't really the whole picture. So what we've done kind of serendipitously is in our use of radiofrequency, we've attempted to treat these patients with radiofrequency. Specifically, we use bipolar radiofrequency. The devices that we use are the InMode Morpheus 8 device, and the reason we like that device, there's two reasons. Number one, it's bipolar and it's adjustable depth. So we're able to treat at different depths, and we know we're traversing the whole skin barrier volumetrically. So the mechanism of radiofrequency, basically it's a heat device, and through a controlled heat injury, we know that we're going to stimulate the vascular endothelial growth factor pathway, which causes lymphangiogenesis, collagenesis, and elastin reorganization. So it makes a lot of sense to have a controlled heat injury in these areas to stimulate lymphatics, remodel the tissue, and allow for a method of egress of this chronic swelling. So we use radiofrequency actually for many different things. As you probably know, most commonly it's used for aesthetic cases, kind of that treatment gap group of patients that need soft tissue contraction but are not excisional candidates. But using radiofrequency in these cases is actually proven to be very effective, and I'll kind of walk you through it. So this is the Morpheus device. As I said, it's bipolar radiofrequency. So the energy is moving from the tip of the needle to the faceplate, which is unique. It's adjustable depth. And they actually have a headpiece that's specific for the periorbital area. It's a little bit smaller, so you can really get into the periorbital spaces. We also like to use Accutite in that area, which is also bipolar radiofrequency. It fits through an 18-gauge needle hole, and we're able to effectively heat the whole treatment area to induce lymphangiogenesis, neocollagenesis, some soft tissue contraction to improve those areas. So these are the devices we like to use. We actually published the largest series. It's a 3-center study, about 250 cases in PRS about 4 years ago. If you wanted to look at the protocols and results and all that, it's in PRS. We normally use it for facial aging, but what we started to realize in patients that have chronic filling, lymphatic obstruction, malar edema, and festooning, it actually has a very unique value proposition in that group. So typically we're using it for aesthetic purposes in patients in their 40s, 50s. The nice thing about this technology is it can be used under local anesthesia or just a little diazepam. It's a very kind of easy, quick treatment and a very safe treatment. So our temperatures, and what we've realized is at these temperatures, you're really stimulating collagen formation. You're inducing lymphangiogenesis, and we published this in PRS, actually showing, using the indocyanine green SPY machine, how lymphatics and perfusion are affected by radiofrequency. So controlled heating actually triggers a wound healing cascade that's very regenerative, as opposed to many of the other devices that we use. So at our temperatures, for the bipolar radiofrequency, we're normally at about 68 degrees Celsius internally. And one of the unique properties of this technology is it's very temperature controlled. So there's not a lot of guesswork in terms of what temperatures we're at. So this is an example of a treatment. Yeah, I'm running out of time, so let me fast forward. So here you can see the Morpheus device. So it goes up to 4 millimeters, 3, 2, and then there's a resurfacing, so we can treat at multiple depths. And this is a demonstration of our lymphatic study showing that after you treat with radiofrequency, the lymphatics are maintained, and actually we get lymphangiogenesis. So I'm running out of time, but I just want to conclude by saying that I think we actually just published an article in the Aesthetic Surgery Journal all about FARI and the treatment protocols using radiofrequency and hyaluronidase together. So if you'd like to take a look at that, there's more detail there. Thank you very much.
For Dr. Dayan, do you think that it's purely a lymphatic neolymphogenesis, or is the heat also causing any sort of remnant hyaluronic acid there that's been cross-linked from the fillers? that is being destroyed, obliterated, heated, and like then the lymphatics are able to transport this out?
Yeah, that's a great question, Neil. You know, I don't think it's fully defined, but we do know that at these temperatures, you do get some degeneration of the hyaluronic acid. The problem is if you just inject hyaluronidase, there's still maybe soft tissue laxity. And so aesthetically, it's not necessarily better, it's just different. So I think adding the heat may break down some of the HA and also remodel some of the soft tissue.
Excellent. Congrats, by the way. That was the most read paper in, I think, all of 2023.
Awesome.
So
I didn't
excellent.
know that. Good.